I am Dr. T.H. Chandrasekhar, your ACG Governor of India region. I am the member of Scientific Committee of World Gastroenterology Organization, and I bring warm greetings from my center, hospital, Medindia Hospitals and Academy, and from the Tamil Nadu Dr. MGR Medical University. We have done earlier two series of almost 24 webinars, and it attracted over 9,000 delegates from all over the world. That really inspired and encouraged us to go for the third series. And this is the webinar, International Webinar Series 3 on Gastroenterology. And we given the title, name the topic, the world experts are here. And with the logo that new Endogeo webinar series news that created a great news, and it is endorsed by American College of Gastroenterology, like earlier the series, and is accredited by the Tamil Nadu Dr. MGR Medical University, and our academy partner being the Micro Labs, and it is an initiative of Medindia Hospital and Academy. The first webinar in this first lecture series was inaugurated by Professor Dr. Jonathan Lighton, President of American College of Gastroenterology. And in September, we had a mega webinar series wherein Professor Barry Marshall, the Nobel Prize winner, was the speaker. He spoke on the journey of discovery of Helicobacter pylori and further. And we had several thousand delegates from all over the world attended the webinar. And really encouraged that these webinars and all possible with the help of my colleagues, Dr. Gokul Satya, Raja Yogesh Prasad, and Dr. Tringana Sambandam. And this became very popular in the webinar series because voluntarily we had several gastroenterologists from all over the country. Dr. Chaubal from Madhya Pradesh, Praveen Roy, Ramesh Kumar, Srinivas Rao, Praveen Kumar, Aravind Gabi, Grish Kumar, Mahapatra, Ashish Kaur, and Nirmaljit from Punjab. So many people really voluntarily came forward. Venkat, Sahin, everyone came from different parts of India. They popularized this webinar series. So we are really thankful to them. And we did have international webinars also from USA, Malaysia, Nepal, and other neighboring countries, and Sri Lanka too. And we had scheduled 12 webinars starting from April, and we had wide-ranging topics from celiac diseases to the H. pylori to the Barrett's esophagus and so on. Now, currently, we are doing the fecal microbiota transplant and the probiotics in GI diseases going to be there. And these webinar series have been accredited by the Tamil Nadu Medical Council, where you get the credit hours. Those who are from other state also can get these credit hours if they report to the concerned medical council. And we must be thankful for our academy partner, Micro Labs Limited, Micro Knowledge Academy. And now coming to this webinar, the interesting topics, fecal microbiota transplant and probiotics, Professor Neil Stallman, and is going to talk on the first topic, and Professor B.S. Ramakrishna, probiotics and GI disease, hyper hope. And I'm going to now, it's a pleasant duty I have to introduce my faculty for this webinar. Professor Dr. Neil Stallman. He is the chief of the division of the gastroenterology at the Alta-Bates Summit Medical Center in Oakland, California, USA. He is the associate clinical professor of medicine, division of gastroenterology at the University of California, San Francisco, USA. He is the secretary and trustee of American College of Gastroenterology, authored book chapters and peer-reviewed articles on various spectrum of GI diseases, and he has several publications to his credit. The next speaker is going to be Dr. B.S. Ramakrishna from India, from Chennai. and a good friend of ours, the director and senior consultant, medical gastroenterology, Institute of Gastroenterology. Earlier, he was the HOD of Department of Gastroenterology, CMC Vellore. He has been the president of Indian Society of Gastroenterology, editor-in-chief of Indian Journal of Gastroenterology. He had several awards to his credit. He was in the editorial board member of Indian Journal of Medical Research. Again, to his credit, he has several hundred publications. Now, coming to my another friend, Dr. Matthew Philippe, he is the head department of gastroenterology, Hospital Kochi. He is the current Secretary General of Indian Society of Gastroenterology. He has got a wide ranging interest, therapeutic endoscopy, endo-ultrasonography, luminal gastroenterology, and he is now taking active part in the Indian Society of Gastroenterology. Another very senior gastroenterologist and well-respected is Professor Dr. Ramesh Ruproy. He is a professor HOD, former Department of Gastroenterology, Government SMS Medical College, Jaipur. Currently is the director of Rai Specialty Care and Research Center, Jaipur, past president of Indian Society of Gastroenterology. And I have a pleasant duty to introduce my panelist also, Dr. Mohan Ramchandani, the director of Interventional Endoscopy Services, AIG Hospital, Hyderabad. Dr. Ajay Jain is a senior consultant, HOD, Department of Gastroenterology, Choitam Hospital Research Center, Indore, and Professor Dr. Ramesh Kumar, Department of Gastroenterology, Osmania Medical College, Hyderabad. Another young gastroenterologist, Rajesh, is a consultant gastroenterologist at Gokulam Hospital, Salem, Tamil Nadu. With this introduction, now I have a pleasant task to hand over the mic to my the first moderator of this webinar series, the Dr. Professor Matthew Philippe, and he will introduce the topic and he will invite Professor Neil Stolman for the talk. Dr. Matthew, please. I will stop sharing.
Yeah. Thank you, TSC and the MedIndia team, for inviting me for this very impressive webinar series, and we are very happy that we have got a wonderful person for talking on fecal microbiota transplantation, which has emerged as a promising therapeutic approach in restoring the balance of intestinal microbiota. And this is an emerging field. A lot of research is being done, and it has been proven for Clostridium difficile, and there are a lot of other emerging fields like IPD, etc. We are. I don't want to say anything more on this because we know that dysbiosis could be a cause for many diseases. And we have none other than Professor Neil Stolman to talk on this very impressive, very interesting topic on alteration or rearranging or reorientation or restoration of the intestinal microbiota, otherwise known as fecal microbiota transplantation. So I welcome Dr. Neil Stolman to start his talk. And I request all other moderators and other faculty to mute their mic during this time. Professor Neil Stolman.
Well, thank you everyone, and thank you all for the kind invitation personally for me to be here. I'm very glad to be here. I'm assuming you can see and hear me okay. If not, please interrupt me because I cannot see you anymore. I'm grateful personally, as I said, to be here. This is a privilege to me. I'm also grateful on behalf of the American College of Gastroenterology. Of course, this is a paired program we're doing together, and we're happy for the collaboration. And while I don't have a Nobel Prize like Dr. Marshall does, I apparently look like Dr. Layton, who you met last year. So that's my claim to fame, and I will be, in fact, president one day. I hope I'm on my way to that. But this morning, for the next 30 minutes, I'd like to talk about this, FMT, or fecal microbiota transplantation in the biome. And I'd like to talk about it in the context of the beginnings of a really exciting new world. And I wish I could tell you, I've been studying this for 20 years. I did my first sort of homemade fecal transplant out here in California 20 years ago. I was the first person west of the Mississippi to do that. I wish I could tell you 20 years later, I know very much. I think we know less than I knew 20 years ago. I think the more we learn, the less sometimes I think that we know. But I will share with you what we do know today in 2025 and what the state of the art is today. I'm going to start with a few slides on how we get our microbiome. I'm going to address the word, what is a good biome or a bad biome? microbiome, and we've already used the term dysbiosis. I may come back to that because I'm not sure it's a great word. Then I will talk about FMT, the fecal transplants, or LBPs. That's the new name for the products on at least the US market, live biotherapeutic products as biome restorative treatments. And finally, I'll conjecture a little bit about what might be coming next in biome therapies for us. I presume in your country, but certainly in my country, we have been consumed by a mania about the microbiome. You cannot turn on the internet or the TV or the newspaper or magazine without seeing a book or an article or a product, in this case soda, that somehow is magically going to fix your entire world simply by fixing your biome. And I'm excited to listen to our next lecture about probiotics, because that's the sort of premise. FMT, I suppose you could argue, is the ultimate probiotic, is the biggest probiotic, is a whole stool probiotic. But there is an insanity in this country about that. I'd like to bring some sanity to that. One quick slide on a few terms that do matter. I will suggest that most of us use the words microbiota and microbiome interchangeably. They're not. There's different words with different meanings. The microbiota are, in fact, the word for the bugs that live within us. When we say the microbiome, I think we mean the bacteria, but in fact, we're referring to the genetic material of all of the microorganisms in a particular environment, in today's case, the colon microbiome. We use this term dysbiosis, but I'm going to come back to that. I'm not sure it's a good term or not. And I'd like to also just suggest that the biome is not just a list of bacteria or viruses or phages, but these bugs do things. And there is absolutely what we call a metabolome, i.e. what is the metabolic milieu of the gut microbiota. So they're not just there, they're doing things. And that is probably just as important as naming the ones that are there. It's what are they doing as well. Again, we're focusing today on the gut microbiome, the intestinal microbiome, but recognize that there's a biome all over us. We have a skin biome, a head biome, a mouth biome, ear biomes. We have biomes scattered throughout. And in fact, if numbers were all that mattered, they would be in charge. There are, in fact, more simply bacteria, forget viruses and phages and fungi, but there are, in fact, more bacteria in and on us than there are actual human cells in our body. And if you look at how much genetic material they have, it's 100-fold. They are, by mass at least, the dominant organism. And we, in some sense, are just a mobile home to carry them around. In the human gut microbiome specifically, we're talking largely about Firmicutes and Bacteroidetes species that make up the bulk of the human gut microbiome. It's also not nearly as simple as you have one bacteria and one outcome, good or bad. Is this bacteria good for us, or is this bacteria bad for us? In fact, they work in families. We call them consortia or communities. They are not single agents with single consequences. They are families, they work together, they help each other, we help them, and they help us. It is a very, very intertwined relationship between the bugs and their host, us in this case, and the bugs and each other. They are relating to each other as well. So what is a good or a healthy microbiome? Let's start with that question. And I'll tell you, I don't know, is the short answer. We know there are at least 800, 900, 1,000 different species of bacteria that live within our gut. There are many, many, many thousands of subspecies. And as I mentioned, it's not just bacteria. There are viruses, fungi, phages that are in there. So we have a catalog. We can sort of make a list. We can do some we can do a catalog. We can give you a list about what bugs are there, but that really doesn't tell us anything. It's as if someone mentioned a trip to the jungle earlier when they were chatting. It's as if you went to a jungle and you came home with a list of the 1,000 different the names of the 1,000 different plants that are in that jungle. You don't know very much about that jungle other than the names of the 1,000 different plants that reside there. And I think at some level, that's an unfortunate metaphor for where we are today with the gut microbiome. One thing that we do think is true is that a diverse microbiome is associated with health, and a more diverse microbiome and a less diverse microbiome is associated with illness. Association, of course, doesn't always equal causation, but that seems to be a uniform truth, that healthy people have a diverse ecosystem or biome. When we take antibiotics or other things or change our diet in a negative way, our diversity goes down, and that is associated with less health. In C. difficile infection, which is what I'm going to talk about mostly today, we very clearly see an increase in proteobacteria and a decrease in Firmicutes that reverse when we fix the C. diff with an FMT. We're also learning that bile acids play an important role, we think, in the gut metabolome, and that the bacteria play an important role with bile acid homeostasis. So this is a very simplistic statement, and it's much more complicated than that, I'm certain. But in normal health, we convert primary bile acids to secondary bile acids, but in C. difficile, we see an increase, a backlog, if you will, of primary bile acids. That's good for C. diff. It helps convert the spores into organisms, but it's bad for us. After we do FMT, we see an increased conversion to secondary bile acids, which are in fact C. diff inhibitory. So again, it's not just the bugs. The point I want to make is that it's what they are doing. So bugs can go bad, and what can happen? We can have an outgrowth of what we call pathobiont, a bad bug. So you can have a bug that is usually present in a small amount, but can bloom into a larger amount. So that's a bad news. We can have an outgrowth of a bad guy, or we could lose our good guys. We can have a loss of what we call our commensals or normal microbiota, particularly due to antibiotics. And with that, we can lose our diversity or richness. And both of those are improved when we do an FMT. But I want to raise the question that I mentioned earlier, association is not causation. The fact that you have these bugs and these bugs does not mean that is necessarily consequential. And in fact, changes may simply be a variety, but not necessarily good or bad. And the phrase dysbiosis implies a bad biome, dysbiosis. And some very smart people, not me, have suggested that we should not use that term. We should use the term of varibiosis to say an altered biome from a baseline, but we don't really know what's good and what's bad. And that's unfortunate, but that's where we are today. So we get our biomes at birth, basically. Essentially, the minute we're born, we go through the vaginal canal, of course, and that is our first exposure to our mother's biome, the vaginal contact and the mother's skin-to-skin contact. And most people think that we get an infant biome signature and that remains largely stable through our life. That may or may not be true. We know that babies that are born with cesarean sections, i.e. who do not get a vaginal biome exposure immediately, seem to have an increased risk of allergies, obesity, infections. And there's some fascinating studies that show if you take gauze pads, you put them in the mother's vagina while she is doing a cesarean section, when the baby comes out, you take those gauze pads, you rub them over the skin and mouth of the infant, and you can show that you colonize that infant and improve that diversity. You can basically mimic a vaginal birth. Now, whether that translates 10 years later or 20 years later into less allergies or asthma, we cannot tell you yet, but it certainly is logical. So it starts pretty much when we're born, and then it also matters, of course, where we live. There is now a science that is referred to as the biome of the built environment, which basically means the world we live and work in. So, for example, people who grow up with pets or with animals, with livestock, seem to have less risk of asthma. And we believe that's due to exposure of their ecosystem. In fact, C. difficile patients who have pets have lower rates of C. difficile recurrence than people who do not have pets. Children who get more early life antibiotics seem to have a greater risk of later life obesity or asthma or IBD. We know that farmers have a different biome than city workers. Sailors, when they go out to sea, have a different biome than when they're in port. Exercise, stress, all of these things correlate with our biome change. So it is not entirely static. We acquire it in our infancy, but these things can certainly modify it as we go. And of course, you're going to be asked every day, how can your patients make their biome better? And these are some general truths that things that seem to be, and I'm cautioning with my word choice because it's not certain, but we think that these help to improve biome health. Fermented foods and fiber, of course, we conceive of that as a prebiotic, as bug food. Breastfeeding is good for our biome. A diversity of food intakes, and mainly plant intake, is better for our biome. Avoiding processed foods, bad for our biome. Of course, antibiotics are bad for our biome. Having pets are good for our biome. And literally playing outside, I send my children out into the backyard and go play in the dirt, kids. It's good for your biome, no matter what. I mean, not going to include a lot of trials, but I wanted to include this one because it reinforces what we just. It was a study out of Stanford. I'm in California, just a few miles from where this was done, and this is a couple of years ago, where they took healthy adults, 36 of them, and randomized them to a 17-week diet intervention. Half of them got a high fiber diet, which we would think would, of course, be wonderful for them. That's a prebiotic and it helps our guts. Turns out it did not really change their diversity at all. The other half were given a high fermented food diet, yogurts, kimchis, kombucha. Now, to be fair, they were given 6 servings a day of a fermented food. That's a lot. And most patients in my community do not eat 6 servings of food a day. But nonetheless, the group that got literally just food, we're going to talk about probiotics next, but these are probiotic foods, if you will. Their diversity absolutely went up, and more importantly, their inflammatory signals went down. And the conclusion is that yes, you probably can counter some biome dysbiosis with augmentation orally of living fermented foods. And I think that's an important thing to show, because I'm going to tell people every day to do this, and it's nice to have science that says that that probably works. Now, of course, our patients with in this, as I mentioned, you can think of it as basically the ultimate probiotic. It is the administration of feces containing the entire gut microbial community from one human to another with the intent to favorably affect their microbiota. This is not new. I certainly did not invent this. There are descriptions in 4th century Chinese medicine texts. Literally 100 years ago, the veterinarians were talking about what they call transfaunation, taking poop from a well animal and putting it in an ill animal and improving their health. The first modern human FMTs, we think, were done in 1958 by a surgeon in Colorado who had 4 patients with what he called pseudomembranous colitis. We presume that was C. diff, but they were not testing. We did not have a C. diff test then. So it likely was. That's, of course, what C. diff can do. But he gave enemas from staff members to 4 patients with pseudomembranous colitis and cured them. We, of course, now have a modern era. I did my first 20 years ago. So 2004, I did my first sort of modern fecal transplant, if you will. The FDA kind of ignored it for about 10 years, and 10 years ago in 2013, they said, you know, that makes sense. This is logical. We're going to let you do this just for C. difficile. So that's the policy they had. You can do FMT in this country until now for C. difficile infection. And in fact, the ACG guidelines that I helped write, I'm one of the authors of this in 2021, overtly recommended FMT for patients experiencing 2 or more episodes of C. difficile infection. Fast forward to last 2 years, when the FDA in this country approved 2 now what they call LBPs, or live biotherapeutic products, that we will talk about. In fact, we are no longer allowed to do sort of home FMT in this country now that we have these products. How can you put poop into someone? Well, pretty much any way you can imagine. We have tried to do so. People have done it via a nasogastric tube, or enemas, or colonoscopy, which is mostly what I do, or with pills. And those are all possible ways to do this. It turns out they all seem to work in a similar mechanism of action. It doesn't really matter how you put it in. What happens is that these new bugs come in. We think they compete for niches, for places to live with C. difficile. They may affect the metabolic output. They may affect our immune response. They may actually directly inhibit C. difficile growth due to the bile acid metabolic effects I mentioned. And in fact, some things in a FMT may actually be antibacterial, maybe bacteriocins, basically. And then this slide just shows one thing. It's complicated, and I don't expect you to see this, but what you're basically seeing in the left column is healthy people. In the middle, people with C. difficile who have less diversity, less richness. And then after FMT, they go back to looking like the original people. But notice, it's not just the microbiome on the top shelf here. It's also the virome and the fungome. These are both probably very important to this as well. FMT works in a simple way because the bugs engraft. That's the phrase we use for that. These are two different studies that aren't important, but they highlight simply, if you look at the one on the left, the graph on the left, there are 5 bars. The patient is all the way here on your far left. This is the donor in the middle, and this is the patient 2 weeks after the fecal transplant. And forget what the colors mean. The recipient now looks a lot like the donor. Likewise, on your right, the donor has a lot of blue and green. The patient has a lot of red. That's a bad biome, too much proteobacter. And after an FMT, the patient now looks a lot more like the donor, i.e. the bugs that we put in work. They set up shop and work. And they very clearly also increase diversity. So the numbers don't matter, but in this scale, higher number is better. It's a higher level of diversity. It's called the Shannon Diversity Index. On your left is the donor, very diverse. The second column are patient, not very diverse. And then columns 3, 4, and 5 are our patients at 1 week, 2 weeks, and 4 weeks after fecal transplants. And you can see that the diversity has gone back up to normal levels. Okay, so we understood about FMT, but we sort of got lucky and we decided the first thing we're really going to try FMT for is this illness called C. difficile or Clostridioides difficile. You know, it used to be called Clostridium. It's now Clostridioides difficile. And we got kind of lucky in a sense that 20 years ago, we said, you know what, let's try this for this illness. This seems to be an illness clearly born of a biome disruption. Let's try to give these people bugs and see if we can fix them. So a few words about C. difficile. It's a bacteria. It is a gram-positive spore-forming bacteria specifically. Infants are often born with C. difficile as a commensal. It does not make them ill. And in fact, of this group of adults, there's 1,000 of you here. 50 or 100 of you have C. difficile in you, and that's normal. That's okay. We can be colonized with C. diff. And in fact, if you put a patient in the hospital, within 2 or 3 days, about 1/3 of them will be colonized. If you put someone in a long-term care facility or a nursing home, about 50% of those people will get colonized. We're also seeing increased C. diff in peripartum patients, IBD patients, immunosuppressed patients. It is the leading cause of nosocomial diarrhea in a hospital. It has a mortality rate in our sick elderly. So it's not just outpatient diarrhea. We have a mortality rate of more than 10% in our elderly with C. diff. I'm going to show you a slide on that in a minute. And of course, we've not so new anymore, but a decade or more ago, we had this epidemic strain, this strain that has a mutation. It's called the NAP1 strain or the BI strain, where there's a mutation in a toxin suppressor gene. So consequently, that bug makes more toxin, and making more toxin, of course, makes people more sick. To get C. difficile, you have to have a susceptible biome, usually due to antibiotics. For most people, that is why we are vulnerable to C. difficile. And of course, you have to get exposed to C. difficile, usually in a healthcare facility. We do transmit this bug from person to person, fecal, oral. So it comes out the bottom, it runs around the world, and it goes back into another person. But the problem is the spores of this bug are incredibly persistent, and they can live outside of humans for months, not days, not weeks, but months, and in fact are very resistant to, for example, bleach or alcohol. They're very sensitive to bleach. Alcohol sanitizers do not kill C. difficile spores, and they can literally live on touch surfaces like handles and toilet flushers and keyboards and steering wheels and refrigerator handles for months in the environment. Once they're ingested, the spores germinate, they multiply, and of course, make us sick. And that's the real problem with C. diff. As I said, you can be colonized and not ill, and that's okay. Although you're more likely to get ill if you enter a hospital colonized than if you don't. That's not surprising. Some people have mild diarrhea. Some people, I'm going to talk in 1 or 2 slides about fulminant disease or a toxic megacolon, and that tends to be the ones who have a mortality rate. Mostly I'm going to talk about patients who have recurrent C. difficile, 20 or 30%, because that's the real impactful problem that we have with these patients who come in, they have C. difficile, we treat them, they get better, and then they recur. And we treat them and they get better, and then they recur, and you can see the numbers there. So we're going to talk about that. A little bit about C. difficile testing. just to make this not confusing, I'll start by highlighting that on the top, we do not do cultures for C. difficile routinely at all. So you may say, oh, send a C. difficile culture. You're not sending a C. difficile culture. We don't do that other than in research settings. On the bottom, there's a test we do here called a GDH, which is just a very, very, very sensitive but non-specific screening test. And a lot of our labs, because it's cheap and fast, will do a GDH. And if that is negative, they stop. You can stop after a negative GDH, but if the GDH is positive, you must confirm with one of the two tests in the middle of this slide. The first one is called the PCR test, or the nucleic acid amplification test. It is inexpensive, it is fast, it is widely available, and it's a perfect first-line test. It is fast and very sensitive. It is not very specific, but it is a very good test upon initial diagnosis of C. difficile. However, once someone has C. difficile, their PCR can remain positive for a long period of time. It is not testing for toxin, it is testing for DNA, literally for bug DNA. And you can have persistence of bug DNA for a long time. So the specificity of a PCR, particularly in someone who has been treated, is very low. And in that situation, we use what's called a toxin EIA, or enzyme immunoassay. Those are the important words, not toxin. It's the IA or EIA, or enzyme immunoassay. That's actually an immunoassay to toxin itself. It is not as sensitive as PCR. However, it is more specific. So initial infection, I would encourage a PCR or a nucleic acid test. But once someone has been diagnosed, I would encourage you to use an EIA test. We do not routinely, you mentioned Dr. Marshall and H. pylori, and of course, for H. pylori today, we routinely test for cure once someone has been treated with H. pylori. But we don't do that with C. difficile. We do not routinely test for cure because, in fact, it's going to confuse us. I mentioned the ACG guidelines. One slide on prevention. That's a better thing to pay attention to than treatment, of course. These are the current guidelines that are out. They suggest, of course, gloves and gowns and isolation. This is a person-to-person transmission. Obviously, antibiotic stewardship is the most important thing we can do. We're going to talk about probiotics next, so I won't jump on that. And we don't like people on PPIs unnecessarily for this indication. When we treat someone with C. difficile with antibiotics, again, in our country, we have three choices: metronidazole, which costs little to nothing; vancomycin, which is also very inexpensive; and of course, fidaxomicin, which is more expensive, at least in this country. For an initial episode of non-severe C. difficile, we recommend stopping antibiotics, of course, if possible, and you can treat people with vancomycin or fidaxomicin, or if they are young and not have a lot of comorbidities, metronidazole, all can be used in an initial case. If they are severe or immunocompromised or have systemic illness, then it's vancomycin or fidaxomicin. Those are our two choices. If they have fulminant infection, we use higher dose vancomycin. We also use intravenous metronidazole. You cannot use intravenous vancomycin for this. It doesn't help. You can use oral vanco, IV metronidazole, and we also sometimes use vancomycin enemas because these patients have an ileus and it's hard to trust oral transit. So those are the things we do in fulminant infection. And I just wanted to show you one really incredible study. This is a cohort study in the Annals a few years ago, looking at FMT in sick hospitalized patients in Italy. And it was 100 plus patients. It was a very large study. And I'll just draw your attention to two outcomes. One, not a randomized trial. It's two different cohorts. But the survival rate in these two arms was radically different. Again, methodologically, there are some limitations here, but significant improved in survival. In fact, you can see it here. With FMT, almost 90%. Without FMT, 58%. Hospital length of stay was halved. And fascinatingly, bloodstream infections, that's what BSI is here, bloodstream infections, patients who got FMT, 2 out of 50 or 4% got bloodstream infections. Patients who did not get FMT, 15 out of 50 or 25% got bloodstream infections, basically bacterial and fungal. So there is a role for FMT in sick and hospitalized patients. But that's all I'm going to talk about that. And mainly now I'm going to talk about patients with recurrent disease, whether they're recurring because those spores are persisting, or their biome is not recovering, or they have an immune deficiency that does not let them respond to the bacteria adequately. Those are, or they get reinfected, that's less common. Those are the patients that we see with recurrence. You can give those people, and should give those people, another course of antibiotics. We typically use fidaxomicin in that case, or we do what we call a tapering or pulse dose vancomycin. And again, that recognizes the spores. In essence, what you do is you give some vanco, you withdraw the vancomycin, let the spores wake up and germinate, and then boom, hit them again with more vancomycin. So that's sometimes how we do that as well. We know that FMT works for this. There are tens of thousands of cases now. In fact, 50 or more thousand cases have been done. I used to have 10 slides on all this data, but the data is unbelievably robust. FMT, whether it's in the upper left, this was the famous New England Journal study with a nasoduodenal tube that showed it worked. This was the first US randomized controlled trial versus placebo that shows it works. There are endless trials now looking at pills and enemas, and it is uniformly, I would say, successful. That is old school FMT, but in fact, shortly we're going to have some new school. In fact, we have new school FMT. So these are two products that are now on the market. Ferring has a product called Rebiota in this country, and Seres has a product which is now sold in this country by Nestle's Health Sciences called Voust. I'm going to talk about both of those for you, but those are now approved. On the bottom of this slide, I will show you one product that is no longer on the market. Finch, which was a stool bank, came out with some pills. They published their data. It works, but they ran out of money. They discontinued their trial. Vedanta has a product that looks quite good. It's sort of non-toxigenic C. diff spores are being looked at, and other Clostridial species are being looked at. And these are coming, but I'm not going to talk about them. I am going to talk about these two. This is the Rebiota product. So this was the product, is marketed in this country by Ferring. It is an enema of whole human stool given one time after standard antibiotics. So this is not isolated therapy. You take vancomycin or fidaxomicin, then you follow that up with an enema, and you can see your probability. Well, look at the bottom right. If you got placebo, the recurrence rate was in the gray. If you got rebiotics, your recurrence rate was in the blue. It was a decrease. And this was published in 2023. And the decrease was 13 or 14%, from 70% to 57%, about a 13% decrease with, or an increase in this is superior. This is not having C. diff, this is having C. diff. So a modest effect from this product, and we use this product today. And then this other product came out called Seres is the company. The product is now called Voust. And this is not whole human stool via given an enema. These are spores of Firmicutes species that are isolated from a human donor. So they come from a human donor, and every treatment you give is from a single donor so that we could trace it back if we had to. And their study was on the cover of the New England Journal, which you're familiar with, of course, because it was a pretty impressive study. And it showed what this is pills, 4 pills a day for 3 days. So 12 pills total, again, after vancomycin or fidaxomicin. And in this case, they use a laxative to flush out the antibiotics. Then you take the pills. And on the left lower here, you can see with placebo, 40% recurrence. With these Voust pills, 12 recurrence. So the recurrence dropped from 40% by another 28%, 28% down to 12%. So a significant risk reduction. And that's why it ended up on the cover of the New England Journal, I believe. I had this slide in here to talk all about an IV infusion of anti-C. diff antibodies that is called bezlotoxumab, or in this country, Zynplava. And I believe I can get this today, but as of tomorrow or the next day, they are pulling Merck, who makes this product. This was also on the cover of the New England Journal. It's a good product. It's immunotherapy, but it doesn't matter because, at least in this country for us, I think it's a reasonable product, but in this country, it's being pulled from the market today, and we don't know why. There is no explanation. It's not for safety. No one has reported any safety issues. It's probably money, but I have no idea why it is. We sometimes have to operate on people with fulminant C. difficile infection. I'm not going to talk about that today, other than to suggest if your patient is completely dying in an intensive care unit, we don't no longer do what we call a total abdominal colectomy, but now we try to do what we call a loop ileostomy with an intraoperative colonic lavage, which is probably better than a total abdominal colectomy. All right, what's coming next for FMT in our last minute or two? I will suggest that ulcerative colitis is probably coming next. That's a qualified answer, but I would think the most likely next indication for a fecal product, a biome restorative product, is likely to be an ulcerative colitis. We now have meta-analyses of at least a dozen trials with over 500 patients, and you can see on the right here, it seems to work. This is clinical and or endoscopic remission, and it is favoring FMT over here. Now, a few caveats about FMT in ulcerative colitis, but probably in everything as well. For one, it's not a one and done like it is in C. difficile. In C. diff, one FMT cures most patients. In ulcerative colitis, it is absolutely not going to be one FMT. It is going to be multiple and recurrent treatments. The second thing we're learning in ulcerative colitis and other indications is that unlike in C. diff, where almost any poop works, doesn't matter what you put in ulcerative colitis, it does matter what you put in. And what we're seeing is what we call a donor effect, meaning some stool donors work better for certain patients than others do. And that's where we are right now, is trying to tease down into which stool profile works for which illness. And that's going to be relevant in ulcerative colitis. Was not so relevant in C. diff because almost everything works. And if you just look on clinical trials, what's going on, FMT is being looked at for everything. There are hundreds, literally hundreds of FMT trials going on for almost any illness you can think of. It is being looked at. I think likely ulcerative colitis will be next, but I will tell you, this is very interesting. Resistance or responsiveness to checkpoint inhibitors is the immunotherapy is a fascinating interest area. Graft versus host disease may be very interesting. Lots of things that are coming that are still not here. So with my last minute and my last slide, I will suggest we have more questions than answers. How do we give someone FMT? I don't think we're going to be giving it via a nasal route or a gastro or duodenal route. I don't think we're going to be doing much colonoscopic FMT, although that is what I do mostly. I hope we're going to be doing pill-based FMT or enema-based FMT is my hope. Are we going to just use healthy young people, random people, or are we going to pair donors with recipients? Are we going to look for a better match of this profile for this illness? And is that going to be whole stool? Is that going to be everything from donor B or donor C or donor D? Or are we going to take out from donor B the things that work? Can we peel out the subset, and that's what the Vouch product is, that we think works? I will just suggest that we've talked about bacteria this entire 30-minute session, but as I've repeatedly said, it's not just bacteria. There are other things there that we have to pay attention to. Indications beyond C. difficile are still to be determined, of course, but I do think this is an extraordinary template. It really is. C. diff for FMT for C. diff is the proof of concept. I really believe that. And now we've shown that. I'm confident of that. Now we have to extrapolate that to other areas. And with that, I will stop talking and thank you for inviting me. And I will be back to speak with you again.
Thank you, Professor Stallman, for this wonderful deliberation. I think we can have questions at the end of other talk also. Is that fine, Dr. TSE?
Dr. Matthew, thank you. And I think that we're really excited to listen to. We after listening to that Neil Sulman, looks like is going to be a new door open for us, not only here in CDI, and a lot of multiple indications going to be there. we are going to discuss after the lecture. Now I'll invite Dr. Ramesh Ruprai to start the proceedings for this second lecture. I see Dr. Mohan Ransundan is already there now as our panelist. Dr. Ramesh Ruprai.
All right. Good evening, everybody. I hope you can hear me. I cannot see you. So,
Well ahead and slides are seen.
all right, sure. So the topic is probiotics in gastrointestinal diseases, hype or hope. So basically in this talk, I'll just briefly go over a very small overview on the background of probiotics and mechanisms of action, because that is something that we need to keep in mind when we look at efficacy. I'll go through the World Gastroenterology Organization's review on efficacy of probiotics in GI disease. I'm an author on that. We'll look at probiotics and see can one size fit all, and then the path to further progress. So if we focus on the definition of probiotics, they're basically live microorganisms which, when administered in adequate amounts, confer a health benefit on the host. Now, we heard Professor Stolman say that Firmicutes and Bacteroidetes are the major constituents of the gut bacteria. But if you actually look at fecal bacteria in humans, and this is from our work, the orange here basically represents Firmicutes. But what is the second most common phylum is Proteobacteria and not Bacteroidetes. So basically, just to make the point that different populations have different bacterial compositions. Also, just to let you know that if you look at lactobacilli, which we think of as probiotics, they form only 2% of the of the fecal bacteria. Bifidobacteria form about 3% of the fecal bacteria. So common probiotic microorganisms constitute a small minority of the healthy gut microbiome. But they have huge effects on gut health. Now again, just to look at mechanisms of probiotic action, there are basically three. Then there's antagonism, and I'm talking of the level of the intestine, exclusion, where probiotics just just adhere to their cells and prevent anything else from coming by. Antagonism, where they antagonize through various effects the pathogenic bacteria, and immunomodulation. Now, immunomodulation is the basis of most probiotic use in disease. A very early experiment from the University of Washington at St. Louis, they showed that germ-free bacteria they have an imbalance in their immune system. So in this particular animal model, the animals had activity of the Th2 type of cytokines and immune system. And this is really what leads to allergic disease. On the other hand, if at birth they colonize this germ-free bacterium with Bacteroides fragilis, it was able to restore the balance. And this was later shown to be largely due to the generation of what are called regulatory T cells, about which we'll hear more in a minute. So if we look at this cartoon here, if these are epithelial cells, gut bacteria condition the innate immune system. So basically, epithelial cells with their villi, microvilli, and here are the bacteria sitting, or bacteria or any other kind of microbes on top. Now, these epithelial cells are part of the innate immune system. The dendritic cells which lie underneath the epithelial cells are also part of the innate immune system. And they put out processes between the epithelial cells. So bacterial molecules, which are basically of different types of patterns. So you can have molecular patterns associated with commensals, molecular patterns associated with pathogens, and they are sampled by the epithelial cells, they are sampled by the dendritic cells, and they interact with antigen-presenting cells. And eventually, these interact with naive T cells to make them differentiate into Th1 or Th2 effector cells or regulatory T cells. This is a bit old, so it doesn't show the rest of these pathways. Now, this is a more recent version, you can say, between the innate immune system and the adaptive immune system, the interface here. Here are the epithelial cells, the bacteria on top. These are the dendritic cells. And so you'll find that number of cytokines are released both by epithelial cells and by the dendritic cells. They act on these naive T cells to convert them, to make them differentiate into Th1 type cells, which are associated with cytokines like TNF alpha, or Th2 cells, which are associated with cytokines like interleukin 4, T regulatory cells with interleukin 10 and TGF beta, and Th17 cells. So as these dendritic cells, they leave the intestine, they go through the mesenteric lymph nodes, they condition these T cells, and these T cells then, the lymphocytes migrate back to the gut via the thoracic duct and the circulation. And they reach the gut, and then they have effector functions in the lamina propria. The reason I'm showing you this is because this goes with the next slide, which is here, that having come here, they then home back to the gut. Let us say they have a defective molecular address and they home to the joints, then you can get sacroiliitis and arthritis. Similarly, you might get uveitis, you might get infection, trouble with changes in the brain and the heart, in the skin, and in the liver. And so this is the kind of hypothetical way in which, or in fact, for several of these things, there is evidence. So there is a phenomenon called oral tolerance, which is that if you keep feeding a protein antigen in small amounts to an animal and then challenge it with a larger amount, they become tolerant to that. And this oral tolerance is presumably induced by T regulatory cells. Now, oral tolerance is deficient in germ-free mice due to the failure to generate these suppressor cells. But if you colonize the mouse with a probiotic bacteria like Bifidobacterium infantis, you can restore oral tolerance. Similarly, oral lactobacillus can restore oral tolerance by increasing T cells which secrete IL-10 and TGF beta. So what is the evidence for probiotic efficacy in gastrointestinal? There's a lot of enthusiasm surrounding the use of probiotics. So the World Gastroenterology Organization has periodically given global guidelines. And this is the latest iteration of these guidelines published last year in the Journal of Clinical Gastroenterology, of which, and I'm here as an author and a reviewer of this. To understand how effective these probiotics are, you can look at levels of evidence. So the best level of evidence is level 1, where a systematic review shows that a probiotic is effective. Level 2 is where there are multiple randomized trials, more than one, which have a consistent effect, but there is not enough to have a systematic review. Level 3 is where there is a single randomized controlled trial. And then level 4 is where there are case series or historically controlled studies. And level 5 is mechanism-based reasoning. So if we look at the diseases where there is evidence level 1, that is where there's a systematic review showing benefit of probiotics, it is only in prevention of antibiotic-associated diarrhea. And in this condition, Lactobacillus GG and Saccharomyces boulardii have been shown to be effective across all studies. Then we move on to evidence level 2, where there are 2 or more RCTs, but there's not enough to assemble a meta-analysis. So here we have several other organisms which also help in preventing antibiotic-associated diarrhea. And then there's Saccharomyces boulardii and lactobacillus, and a mixture of lactobacillus acidophilus and casei, which prevent C. difficile associated diarrhea. And then we have a number of preparations which are used as adjuvant therapy for H. pylori eradication. Now, they don't actually accelerate H. pylori eradication. What they do is to prevent the side effects of the antibiotics which we use, and therefore they allow the therapy to be completed. And here again, in evidence level 2, there are a number which have been used in irritable bowel syndrome, including a number of these. There's a study in NAFLD or MASLD with Bifidobacterium longum and a prebiotic. And then there's study in hepatic encephalopathy prophylaxis, where also there is level 2 evidence showing benefit. Coming then to level 3, which is a single randomized controlled trial showing benefit, there are several preparations which have been shown to be effective in the reducing severity of acute diarrhea in adults, preventing antibiotic-associated diarrhea, and preventing C. difficile-associated diarrhea. Here again, multiple studies where multiple different preparations which have each a single RCT showing efficacy in IBS, and here multiple preparations, single studies showing efficacy in functional constipation. Coming again to this with pouchitis, induction and maintenance of remission, all level 3 evidence, induction of remission in ulcerative colitis, maintenance of remission in ulcerative colitis, and again an MASLD. So here we have a number of preparations which are reviewed in the WGO guidelines. Now, what are some of the pitfalls in the evidence? One of the problems with this is that every trial, none of the trials all uses the same preparation, none really uses the same dosage. The endpoints at which they are looking may all be different. And that is illustrated by these trials in IBS, where if you look, there are a huge different number of preparations. Some of them use colony forming units. In other words, they are not live bacteria. Some use live bacteria. Some administer them once a day. Some administer them 3 times a day. Some will administer 10 million and some will administer 10 billion. And if we look at the endpoints, there's improvement in global symptoms, there's reduction of pain, there's reduction in persistence of symptoms, decrease in pain and improvement of constipation. So a whole variety of things. It's very difficult to actually make sense of this and say, use this for such a condition. Scientifically speaking, or theoretically speaking, can one size fit all for probiotics? And it seems, and if we use the analogy of inflammatory bowel disease, it seems that it will be unlikely. For instance, we know that multiple pathogenic mechanisms drive microbiota-triggered inflammatory bowel disease. For instance, here there is adherent invasive E. coli, which causes ileal Crohn's disease in smokers with NOD2 mutations. So it's a very specific condition where you have these E. coli, and these people will have to be smokers and they'll need to have a NOD2 mutation, in which case this bug induces Th17, IL-17, and then leads to inflammation. So here, whatever probiotic you use will have to have one of these things along this pathway as a target. On the other hand, you have the Ruminococcus nevus, which is there in many people, but which overgrows in Crohn's disease. It produces a polysaccharide which acts on dendritic cells to get them to liberate TNF-alpha. So here, this is a different mechanism. And somebody who has an IBD due to this will probably require a different probiotic. Here's the third type where there are these oral Klebsiella, pathogenic Klebsiella, which translocate to the ileum, overgrow, they stimulate dendritic cells, and then they make them go into Th1 maturation. And through the macrophages, they get secretion of Th17, the IL-17, and so this leads to inflammation. So there are multiple mechanisms, and it seems only logical that each mechanism is going to require a different kind of probiotic. And in each of these, it is also triggered by the genetic makeup of the host. So what is the path to the future? There is a need to individualize probiotic therapy. So if we look, here, and so these are multiple controls, multiple Crohn's disease, multiple ulcerative colitis patients in whom we used a chip to look at different microbial communities, and you see that some microbial communities are hugely increased. The red ones are all show an increase. The green is where they are downregulated, and so you see these are markedly increased in ulcerative colitis. So you might need to genotype the microbiome in your patient. You might need to genotype the host to find out which specific mutations they have, which allow them to interact with these microbes in the gut, which then cause inflammation. So essentially what this will require is to get large cohorts of patients with diseases that involve microbe-host interactions, in whom we can phenotype the host, we can genotype the host and the microbiome and predict pathways of disease. And if we then use AI, which is obviously coming, you'll be able to understand which probiotic or which bacterium or which bacterial product might be useful in a particular situation. And this is elucidated in a similar way by Balfour Sartre in 2020. So Dr. Sartre has done a lot of work on microbes and Crohn's disease. He himself has Crohn's disease, so I think he's motivated to do this. But what he suggested is that you need to do a fecal profile, look at dysbiosis-targeted pathways, protective pathways, inflammatory pathways. So you basically phenotype the individual, look at the mucosal profile, then see if they have dysbiosis A, B, or C, and then based on the permutations and combinations, you use specific bacteria or bacterial products. So I'm going to sum up and say that the strongest evidence for probiotic efficacy is in prevention of antibiotic-associated diarrhea. There is less strong evidence for probiotic use in preventing C. difficile-associated diarrhea, in treatment of acute diarrhea in adults, IBS, functional constipation, MASLD and MASH, hepatic encephalopathy, ulcerative colitis, and pouchitis. At present, there is no evidence for the use of probiotics in Crohn's disease. So the future lies in personalized medicine, tailor probiotic use according to host genotype, phenotype, and gut microbiota. And with that, I'll stop. Thank you.
Dr. Roy? Yeah.
Yes. Are you able to hear
So
me?
you can start the proceeding, Dr. Roy, and Matthew can
Yes.
join, other panelists also join. Dr. Roy, please.
Yes. Excellent talk and so much of good summing up, whereby you are telling that except probably one indication, the probiotics are not very useful. And there is a $85 billion industry which is roaming, and every one of us is confused, but you have made it very clear. So just to start the discussion, as you have rightly mentioned, that it is all dependent on which type of bacteria or which is lacking or the commensal is there and which has changed. Now you have to tailor the treatment according to that. So whenever you are available for antibiotic-associated diarrhea, can we give both the antibiotic as well as the probiotic at the same time, or we have to give them at a different timing?
Thank you, Dr. Roy. Thank you for that question. So it should be feasible to give the antibiotic and the probiotic to actually co-administer them. And I think if you think back to your childhood, I don't know, Dr. Roy, we are of the same vintage. So if you think back to your childhood, you'll remember that we had antibiotic preparations which also incorporated probiotics.
Yes, sir. Yes.
Yes, and even now you do. I mean, doxycycline with Lactobacillus plantarum is sold. You know, it's called Doxy something, Doxy L1 or something like that. And the thing with the probiotics is that most of them have an intrinsic. They lack the targets for these antibiotics to act. So they're intrinsically resistant. It's not a transmissible resistance, but an intrinsic resistance.
So,
Okay.
so we will have it like that, Dr. Roy. One question from you, then Matthew Philip, then all four panelists will ask questions to the speaker. Then any controversy or comment will have that. Now the next question by Dr. Matthew Philip to Dr. Neil Stallman. Dr. Matthew. Dr. Matthew Philip, while he is coming to the thing, we have Dr. Mohan Ramchandani. Mohan, so you have started their FMT in AAG. What was your experience and what do you like to ask Dr. Neil Stallman?
I think in India we started that and it was very successfully. We used in two main conditions. One was Clostridium difficile infections who are resistant to vancomycin. And the second where we started using was ulcerative colitis. Unfortunately, with the advent of COVID, this program was slightly, taken back, and now still we are not regularly doing, but as and when need arise, we have a full lab available, and if donor selection is proper, we also offer them. But so my question to Dr. Stallman is, first of all, fantastic presentation, and you have shown us so much data on efficacy of Clostridium difficile in the setting of Clostridium difficile. My question is, what are the difference in efficacy of FMT in refractory C. difficile or recurrent C. difficile, or do you offer this treatment as a first line without even offering vancomycin or other drugs in the treatment?
Yeah, it's a complicated question, and I'll try to simplify it. But as you've learned, I speak fast, so I will cover it. Thank you, Dr. Ramchadi. That's a great question. So to the last question first, what about primary treatment? That's a fabulous question. We talk about that a lot. I don't think anyone in this country is yet ready for that. That's not to say it's not right. It's just we are not yet. Meanwhile, the companies that do this, they want us to. I mean, they want us to. Of course, they want us to use it sooner. There are studies looking at primary treatment. It's probably reasonable, and the data is very small still, rather compared with recurrent or refractory, two different illnesses. I think right now the problem is still an unclear safety. I mean, it's been largely safe, but we've had one fatality in this country with an FMT from a drug-resistant E. coli, a EBL, a multi-drug resistant E. coli. There's questions, I think, about that. The expense is substantial. Those Vouched pills in this country cost $18,000. They're very expensive. It's a very expensive thing to do, and vancomycin might cost $100. So I like the idea. I acknowledge the logic of it, and I suspect when Dr. Ramakrishna gives us the right set of pills for the right illness, we'll probably do that. But I think it's still too early. And that's the holy grail, right? Is that personalized approach. Exactly that. But I don't think we're ready for primary treatment yet. So I like it conceptually, but I don't think we're going there yet. The data for recurrent disease, using whole stool from the stool banks, and we have that data, is 80%, 90%. It's very, very,
Yes.
very effective in that population. Not refractory, different from refractory. This is now recurrent. You respond to antibiotics, whether it's Vanco or Fidax or metronidazole, but once we stop it, it comes back. Those are the people who do wonderfully. And I'm very aggressive with that population because they get better. I mean, the data is unequivocal, tens of thousands of people, 80, 90% efficacy. And then there's the
cost.
the
The
refractory.
cost is the one is going to decide. You may not like to start at the initial first line treatment without trying vancomycin. So, what is your take, Dr. Mohan? After that, we will ask Dr. Matthew to start the question. See, cost is what is? Did you work out the cost? You said
Yeah.
straight away go for that FMT versus vancomycin.
Yeah, so the cost of FMT in AIG, it was not very high to screen the donors. It required around 15,000 rupees to screen the donor, and we were offering the FMT around 30 to 50,000. So the cost was not high at that time.
Yeah, and the cost
Compared
here,
to
by the way,
vancomycin.
Hello.
My philosophy is taking
No,
as a first line
easy.
treatment before trying. Okay, Matthew, you want to ask some question and comment?
No, I just want to make a comment on the cost. I've been doing this FMT for IBD since some time. And after COVID, it has definitely come down and I have to move to another institution. So I'm building it up. So I tell you the cost is mainly the screening cost and the procedure cost. Doing a colonoscopy, suppose you put through a tube. Sometimes we have done for Crohn's disease putting a nasogenital tube, or in some, if it is enema, it's not very expensive. But if you have to do a colonoscopy, the cost of colonoscopy comes. Otherwise, as such, for the cost of fecal myocardial transplantation, as such is not very expensive. But the screening is important, and that procedure itself is important. If you are not given as a enema, if you are giving a colonoscopy. But I have got a question to both Dr. Stallman and to Dr. Ramakrishna. See, what is the basic difference between a FMT and giving a probiotic or a packed bacteria in a capsule? Is there any difference? Why it is not working when you are giving only bacteria and other is giving FMT? Is it because of the other contents involved, like metabolomes or other things that are important? First, Dr. Stallman, then Ramakrishna.
Sure. It's an amazing question, Dr. Philip. Thank you. And I agree with you. There's no answer. It is certainly whole stool is a different thing than purified bugs, right? Those are sort of defined consortia as different than whole human stool, because whole human stool has all these other things in it. It's not just these bacteria. It's an active milieu, right? Now, the Voust product, which is now available in this country, I don't know if it's available there, is 10 different spores of Firmicutes. That's what it is. So yet it's sold as an FMT LBP product for a very expensive price. But how is that different than VSL number 3? Than a packet of, these are 10 different Firmicutes spores. Why is that different than anything else? And I agree with you. I think there's a continuum from defined personalized medicine, as Dr. Ramakrishna was advocating, rightly so, to the spectrum of whole stool. And where the line is from fecal transplant to probiotic, I don't know. No idea.
No, Dr. Ramakrishna, what is your take on that?
So there are two basic differences. So if in the gut, we are talking about 10 to the power of 14 bacteria, which is, say, 100 trillion. And if we give, say, even, let us say, 10 billion or 100 billion probiotics, it's probably not the same as an FMT in terms of volume of bacteria that we're giving. Numbers, that's one. The second thing is that when you put in a consortium of microorganisms, the effect is different from putting in a single microorganism. All of these microorganisms interact with each other. Their metabolism is such that they interact with each other. For instance, I can tell you something from experiments I used to do decades ago, which is to look at the way these bacteria ferment carbohydrates to form short chain fatty acids, right? So if you put in single bacteria, you will get a certain, let us say, mixture of metabolites. But when you put in multiple bacteria, you get a whole different range of metabolites, because other bacteria use something put out by this one, and then it keeps going around, so that what you get, the end result is different. So that is where the difference is. But at the moment, the problem with both, there are problems with FMT, there are problems with probiotics. The medium is somewhere in between.
Right. Where's the line? So you said a consortium versus single, but where on that spectrum does a probiotic become a biotherapeutic product?
And Dr. Ramesh, now one quick thing. Now you are done a lot of studies on colonocytes, short chain fatty acids, and on. Do you think using? I know that you have done some studies also on using short chain fatty acids for treatment for this type of disease. Do you think that there is any role now using short chain fatty acids instead of this type of therapy?
At this point of time, no. And also, I think short chain fatty acids, probably their main interest, their main use at one point of time was in diversion colitis,
Yeah.
Where it looked like that they would dampen inflammation and promote epithelial cell trophy. But I think the use of single or mixtures of short chain fatty acids has limited applicability now.
And I question to Dr. Stallman, in your country, is FMT is covered by insurance?
Gigantic problem for us. Well, it's changing in a good and a bad way. So until literally this month, we had a stool bank, something called Open Biome, a couple of stool banks, and the FDA let us just get poop from stool banks. Now, it wasn't typically covered, but it was not expensive. Now we have these two FDA-approved products that are very expensive. I mean, in the $10,000 to $20,000 range, tenfold what it was. You know, you guys were talking about making it up in your lab. It's not that expensive to make. And when we were getting stool bank stool, it's now 10 times more expensive. But in theory, because it's FDA approved, the insurance company should pay for it. They don't. And we fight. I will spend an hour of work almost every day fighting exactly that fight. One of the best reasons not to work in my healthcare system is that I have to fight for every single one of them.
But in India also, I think insurance has not taken that, no? What do you think, Matthew?
They don't know. They don't know it. Actually, one of my patients got insurance, but they never knew about what it is.
Right? They don't know. They do not know.
So,
Morgan, what is your take on insurance? Did you manage to get an insurance because they did not know, so they accepted it? You didn't try insurance at all for that. You're muted, Mohan.
So we have also same problem that insurance doesn't recognize this, and they are not well educated on this. And
but Matthew had other problem. Since insurance did not recognize, you got the insurance clearance.
No. Now in India, that is possible. But I'm sure they will actually. All these companies are coming. They are international chains now, no? So they will be actually coming into all these ideas.
Okay, I will come back to you, Matthew, again. Dr. Ajay, you have a comment or question? No. Ajay?
A great talk by both the speaker. Am I audible?
Yeah.
Yeah, you're very much audible.
I enjoyed a lot of new information. Maybe most of us must have got those information. Now, my question to Dr. Ramakrishna, because he belongs to this country, is there anything which has been done on curd or yogurt as a prebiotic therapy in ulcerative colitis? Because I distinctly remember one of these scholars of Vedas was describing curd enemas in the treatment of diarrhea. So is there anything which is available or anything which he has come across in the literature?
Thank you, Ajay. No, I'm afraid not. I've not seen a proper clinical trial on curd enemas in ulcerative colitis. It's an intriguing concept.
Okay. And
How about any study on yogurt, Dr. Neil Stallman?
There's, as Dr. Ramakrishna mentioned, there's reasonably good data that yogurt co-administered with antibiotics to the point of earlier separate or together can lower antibiotic-related diarrhea. I believe that data is fairly supportive. So I do tell my patients to eat, when they're taking standard antibiotics, to consume a higher ratio of yogurts and kefir and kimchi and kombucha and all of these things.
Well, it is Dr. Mechnikov who got a Nobel Prize. He first demonstrated the beneficial effects of the yogurt. I think for centuries, Indian diet has included yogurt as the curd, what we call it here, maybe yogurt there we have included. Particularly in South Indian diet, never ends without the curd. Then we'll move on to Dr. Ramesh. You have a question and comment to both the speakers and other panelists. Matthew, you are muted.
TSA, I want to make a comment on that. You have told
Yes.
that South Indians are taking a lot of yogurt and curd, but IBD is highest in South India, isn't it? You have got a lot of Crohn's disease. Probably the highest in India is in South India of Crohn's disease. So probably
No, it
this
is off
cannot,
late, Matthew. 50 years before, we did not see any Crohn's disease. Now, probably we are taking less amount of yogurt and curd, the current generation maybe. We really don't know. We need to explore that. Dr. Ramesh, before I will come back to Ajay again, and Dr. Ramesh, be ready and unmute yourself, Dr. Ramesh, and I want Rajesh also to be ready with his question. Then Dr. Gokul.
Yeah.
Yeah, Roop Rai after that.
What are the potential pathogens that are not screened during the donor stool collection?
Okay, question, Dr. Stallman.
Yeah.
I'm sorry, the question was what is the parameters?
What are the
pathogens not screened during donor stool collection.
Yeah,
What are the-
so
Yes.
so now that's gone away because we've lost our stool banks. But so I used to work with Open Biome to determine what the panel is, and it changed every month. We added new bugs, we took bugs out as bugs. COVID, of course, was a gigantic problem because that can be found in stool. We don't believe it was transmissible, but it certainly can be found in stool. So we're constantly in evolution. Right now, I'm working with a group trying to define a standard for that. And I'll tell you, nobody really knows. It's going to be some smart people drawing some arbitrary lines and saying, these are the things we know about that we can test. If we know about them and we can do a test, let's do that test. But I mentioned the fatality in this country. It happened with a bug that we weren't testing for. It was not because we didn't test right. It was that we weren't testing for that bug, and we found a bug, and it caused sepsis and a fatality. So we're constantly expanding what we test for, but it's in evolution. And as we know, I'm always worried there's going to be another hepatitis, K, right? We haven't yet learned about. Hepatitis L is coming at one day, and we don't know about it yet. So that is part of, by the way, what tempers me for sort of primary FMT treatment is our inability to really screen perfectly.
Okay, now Dr. Rajesh, you have a question and comment
Yeah.
to both the speakers and other panelists.
BSSR. So you have summarized it very nicely. The only level 1 indication is for antibiotic associated diarrhea prevention. In that case, do you recommend routinely to prescribe probiotic for all patients? Because your left and right, you are giving antibiotic in a day-to-day practice. So you routinely recommend probiotic for all patients you are starting antibiotics, and that too, it's the very first day, and how long to continue along with antibiotic?
So certainly there is a rationale for doing that. There is evidence which is fairly conclusive. There is a rationale for doing that. But you have to temper that with the fact that sometimes we give antibiotics in a hospital setting, we give antibiotics to very sick patients. And as a rule, I would not give probiotics to very sick patients in or out of ICU.
Okay.
Yeah,
So you
Dr. Rama,
routinely
can I-
recommend.
Can I ask a question to Dr. Rama regarding this one? A suggestion. See, there are some studies saying that in pouchitis, probiotics are good. Pouchitis.
Yes. So the only large series is Gianchetti's series from Italy. And I mean, obviously, because pouchitis is not such a common condition that you have RCTs. And what they showed was that what used to be then known as VSL3 was effective in inducing and maintaining remission in pouchitis. So yes, under those conditions, yes. But I must remind you that the preparation that they use is you have to give large numbers of viable bacteria. And what we are doing is we're giving a tenth of actually what they were using.
Okay. Dr. Gokul, you have a question. After that, Dr. Ramesh will be asking a question.
Good evening. It was great listening to both the speakers. I have a question to Professor Neil Stoneman. So we understand that cholecystectomy is a commonly done surgery worldwide. And we also know that it can lead to dysbiosis because of excess bile acids coming to the colon. So that can lead to colitis or even sometimes cancer. So how significant is this problem, or according to you?
I think we don't know yet, and I know that's not a satisfying answer, but I think it is still very much in flux. We've known that observation long before we were paying attention to the biome, right? We've known that cholecystectomies can lead to maybe a biome disruption, a bile salt disruption and a higher risk of perhaps colon cancer. That observation has been for decades and decades before we even looked at it from a biome perspective. And it's really only in the last decade that we've understood, I think, how very central to biome health bile salts are. Bile acids and bile salts are very, very integral. So I think your question is a profoundly important one. I wish I could give you a data-supported answer. We don't know that, but it's logical, certainly. We know that bile salt flux is important to C. difficile very clearly when we look at that, and probably other things. But we've proven these things in C. diff, and then the question is, can we prove them outside of C. diff? So we have this nice little system, this little test case of C. diff, which is not in and of itself a world-changing disease, but has been our laboratory for this, because it's an almost perfect system of a disrupted biome that we can cure with biome restorative therapies, right? It's really the opening salvo of that. I think it's real to your question, but I cannot more precisely tell you. And it's a good reason not to just take out a gallbladder unless someone genuinely needs their gallbladder taken out.
You have a question to Dr. Ramakrishna.
Sir, Professor Ramakrishna, sir, thank you for the nice talk, sir. So what is a common side effect you have noted by prescribing probiotics to patients?
So I've never actually noted side effects in prescribing probiotics. So I think they're extremely safe. But there are isolated incidents, case reports of septicemia, endocarditis, and so on from the probiotic use. And therefore, I generally hesitate to use them in somebody who's very sick.
I will add to what Dr. Ramakrishna said earlier. It's very important. We've seen Dr. Ramakrishna mentioned Saccharomyces boulardii, which is a very interesting yeast, not a bacteria. It's a yeast that maybe has an interesting C. difficile role and perhaps some other roles. But we have reports now of people getting funginias, particularly people who have indwelling catheters. So we have a pretty strong prohibition on probiotics in sick people, exactly as you said, Dr. Ramakrishna. But in my case, I very much look for, if you have a port, if you have a dialysis catheter, an IV, any way into your body that's not oral, I'm very reluctant and I try to avoid them.
Thank you.
Dr. Ramesh Rupral.
Yes, sir.
Then we are going to start the second round now. So we'll have one more round to go. Okay, Dr. Ramesh Rao.
Dr. Balakrishnan, Saccharomyces boulardii has been used in many patients. Saccharomyces also is there. There is a question that can it cause the SCA positivity? SCA positivity.
I'm afraid I don't have the answer to that. But I guess
I
if
don't
you give
either.
it to somebody with an ulcerated bowel, it could. I mean, because I don't have the answer.
I do think it's a good bug. I don't want to villainize S. boulardii because while we do have reports of fungemias with it, in fact, it probably has some of the best data in the C. diff world, where people are very focused on bacterial probiotics. The data for S. boulardii is equivocal, but probably better than any of the bacterial data. And I use it still, admittedly, anecdotally, in my C. difficile patients. I think there's a role there.
Okay, Dr. Matthew,
Yeah.
do you have any
Process.
second round?
I would like to ask a question to you. In one of the slides, you have shown that frozen sample versus the fresh sample is almost same, or frozen sample is slightly better. And for the FMT, in that context, do you think that is it better to have a frozen sample, and when the motion comes, use purify it and keep instead, or strain it and keep in as a frozen sample, or you take every time separately? Because in our situation, I generally, when I started using, I never used the frozen sample freshly taken up, and there are a lot of challenges on that. So do you think frozen and multi-pooled or a pooled one, is it superior than a single isolated separate, or it is a non-frozen one, which is better?
So there's a lot of data looking at frozen versus fresh versus freeze-dried. So there's multiple. I think the slide you're referring to showed actually three different. In my lecture, I'm not sure if it was Dr. Krishna's or mine, but one of the studies I showed looked at frozen, fresh, or lyophilized, which is freeze-dried, basically, and they were all identical. They were all, now that again is in C. difficile, where everything seems to work. So we got lucky because it almost doesn't matter, singular donor, multi-donor. In C. difficile, the cure rates are so high that it's hard to tease out any of those differences. I think it will be significantly different in other illnesses. And I absolutely think there will be a difference in fresh versus frozen versus multi versus single. In our country, the FDA wants uni donors for safety, not for efficacy. They don't care about efficacy. They want us to use one donor for one patient so that if there is a problem, we can trace it back. If you use a multi-donor and you have a problem, you can't back trace it. But that's not because that's medically advantageous. That is solely because they're being very cautious.
One question open to all, including everyone. No, what are the challenges you face in the donor selection? I have in Kerala a lot of challenges, and in USA, what is the challenge you face to get the donor, select a donor?
The challenge is what the FDA wants us to test, not the donors. We have lots of donors, people who it is not that complicated. There's a lot of young college students who will happily we pay them, so we will happily, and you could argue about the ethics of paying a donor, but it's not hard to get the donors. The hard part, the challenge is how broad is my screening, and how the more broad I make it, the more it costs, obviously, and the longer it takes and the more people I exclude. So where is the circle to draw? That's, I think, the current challenge.
Matthew, I think the selection of donors, there's no scarcity like other organ.
No, I tell you.
Only thing is, what I'm telling, how good you come to know that how healthy he is, and how the pattern. So you have a questionnaire for that, like a stool pattern, diarrheal pattern, or okay. Like an antibiotic recently or something like that.
Rama and Mohan, anything. In Kerala, what I face is that, Kerala people are 90%, 95% they are non-vegetarians. And it is a big urban area. There is no village. So if I want a good stool donor, I have to go to the village. Those who are eating only vegetables, or they are taking less of red meat. So, I should have a person without pot belly. I need a person without obesity. So I think in those people, the microbiota is much better. It's very difficult to get such a person. So what I usually ask,
You may not prefer a person with a non-vegetarian as a donor.
yes, of course, vegetarian foods, that will have good microbiota in the intestine, not non-vegetarians.
So the other part I understand very challenging, not having a pot belly. So that will be a more challenge.
Obesity people, obese people have their different microbiota.
So you would not like to have that? Okay, Mohan, what are your challenges with the donor selection or any other question you want to ask the speaker? We have
cultural challenges. Cultural acceptance of fecal transplantation in India is slightly, they are slightly resistant. The acceptance level is not that great. So the people are taken aback once you say fecal transplant because of maybe the lack of education and awareness. Apart from that, prevalence of multi-dig resistance carbapenem or any, this is very common in India, which needs a very strict donor selection. So these are some of the things. So my question to Dr. Stolman is that I recently saw a report in gastroenterology where 5 patients were given a sterile fecal transplantation that was not associated with microbiota, but that was like filtrate which contained bacterial debris, protein, antimicrobial components, metabolites, but not bacteria. So that brings a lot of safety into the FMT, but they were very effective. Even they does not contain microbes, but they contain these metabolites. So what is your opinion on this?
Oh, I'm so glad you brought that up, Dr. Ramchandi. I, in fact, have a slide on that, but because I only had 30 minutes, in my 45-minute talk, you would have seen a slide on exactly that study, because it's a fascinating study that you're referring to, which was, to just paraphrase it, basically a sterile filtrate. They just took stool, they filtered it, so there was no living bacteria. That's what they excluded. There was no living bacteria that they could identify if you cultured it. It was 5 patients with recurrent C. difficile, and they said they cured 5 out of 5. That's the report. And now, mind you, very small study. The cure rates, no control arm. We know that the control arm in some of our studies is 50%. So 5 patients uncontrolled is challenging to extrapolate from. And interestingly, I've not seen anyone try to confirm or refute it subsequently. That's the only one I've seen, but it raises this critical question that I hope I was emphasizing repeatedly, that it's not just these X bugs. It's not. It's the other things. The viruses may play a role. The fungi may play a role. The phages may play a role. The bile salts may play a role. It's a very simplistic thing to believe it's these 7 bacteria. And I think it's clearly wrong to think of it as these 7 bacteria.
I think I'm taking the Dr. Mohan question little different way. The concept of a dead bacteria, that's the one we are more want to know, but this is right or wrong. I just wanted to know that. Because even though the volume of number only 5 patients, okay, but the concept itself is it, how do you look at that?
I'm sorry, I didn't understand the question.
No, yeah, I'm not worried about the volume, 5 patients only. Maybe after that we can do a larger study later on. But instead of having taking a sterile stool, is it right to FMT? That's the reason I'm asking. What is your reaction to that?
My reaction is that we don't know anything. We know so little that my reaction is it highlights how ignorant I pretend to know this, and I will disclose I don't.
So they named it not FMT, they named it as FFT, that is fecal filtrate transplantation. So
FFT. Okay.
FFT. So that's
now,
but it
before
was
Ramesh asked, FFT. Okay, before Ramesh asked, Ajay, you have any other question, Ajay Jain? And then Ramesh, you have the question now?
Dr. Rama, Dr. Ramakrishna.
Yes.
See, recently one company launched one by name PSLV, that using 4 probiotics. So what is your take on this PSLV in using in our clinical practice, especially this Peptostreptococcus and PSLV, Saccharomyces boulardii and Lactobacillus. 4 strains have been used by one company by name PSLV. So, what is your take on this?
Uh, so I think, like I said, consortia of microbes. I mean, so like we have a yeast and some bacteria put together. They may well have an effect, but any of this will have to be tested in a clinical trial. And unless we have a clinical trial, it's hard to say that something is effective or not effective. Having said
Rama,
that, it's very easy to sell probiotics because all you need to say is not to have a specified health effect. You can just say it promotes health and leave it like that, and you can sell it.
Gut health.
Gut health. Yes.
Rama, I want to know Ramesh's question. I want to dilate upon. More is a merrier in FMT because you said when you are prescribing a probiotic capsule versus FMT, more number of bacteria, more consortium. So you're having PSL, whatever he said, 4 bacteria, 4 type of bacteria. So more is the merrier, huh?
Yeah, to an extent, yes, but the quality also matters.
That means some company comes with 10 bacteria, you will be happy then.
So there are. It's certainly likely that consortia are better in dampening inflammation.
That closely imitates the FMT, no? We have more bacteria. Okay. Ajay, you have a question?
Yeah, I have a question regarding this biosis. But again, this is a very provocative question. As we are moving more toward the RO water these days, has it changed the microbiota and has it led to some of these problems more? Because some 20 years back, in medical college, there used to be one cooler, and we used to, sometimes without water, and we used to drink water, and we never had diarrhea. These days,
I think one of the slides Dr. Stallman showed roll in mud.
Roll in mud. And I stand by that recommendation. I will back up that recommendation. I think, Dr. Jain, you're right that this sort of this modern hygiene thing is a good thing. Of course, we've eradicated. I'm not suggesting that we shouldn't have antibiotics or hygiene. Of course we should, because we've eradicated all sorts of illnesses. But there is such a thing as underexposing, particularly children, right? Like the gauze on the baby. Our children need to be exposed to bacteria, whether that's in water or on their hands or in the mud or from their vaginal birth or their food or their breast milk or milk or fermented foods. We have to. And I think there's certainly a thesis that a lot of a modern illness like IBD and food allergies and things absolutely have to do with inadequate mud.
One more question. This is to Dr. Rama, has the increased consumption of cheese in India has led to an increase in microbiota associated disease like IBS and C. diff diarrhea and other things?
So
cheese, you mean cheese, huh?
So IBD has certainly increased, as Dr. Matthew Philip was saying. It has increased in the last few decades. One of the reasons, obviously, it's changing habits. Whether it's sweets, it's a possibility. Whether it's increased iron, because iron promotes pathogens, promotes inflammation, etc. And that incidentally, it was suggested by Dr. Mohandas, our gastroenterologist, the cancer Mohandas. And there are several other things to it, but certainly, yes, it is something to look into. That's something to add to the questionnaire when we do studies on epidemiological studies on IBD.
Okay, last question by Dr. Rajesh. After that, I have 10 minutes to go into the chit-chat session to know more about our faculty.
Again, to Rama sir, we commonly use probiotic rather than FMT. And what is the storage conditions of commercially available probiotics? Whether it's refrigeration is a must, because there are live bacteria, there are colony forming units. You advise them, it's a must to store in a refrigerator or keep it in the room temperature.
So it would depend on what we are using. So if they are spores, then they probably don't need to be kept in the cold. If they are live bacteria or if they are desiccated bacteria, it's probably still better to keep them in the cold. If they are live, they certainly have to be stored in the refrigerator at 4 degrees.
Okay, now we have come to the last 10 minutes is exclusively for the chit-chat session. Now we'll start with the Dr. Ramakrishnan. What is the last non-medical book you have read?
The last non-medical book I have read, I would say it was yesterday.
Oh, very good.
And it said Dr. John Scudder, the first medical missionary in the world.
So how do you get time for this? You go home by 10 o'clock, you live near my hospital, and you get up and so early. So how do you make the work-life balance, Rama? What is your mantra?
Nothing. I think the mantra is to enjoy what you're doing.
Okay, right.
Yeah.
Dr. Neil Stolman, what is the last non-medical book you have read?
Well, I just flew for 12 hours yesterday, so I had a lot of reading time, in fact. And I am in the middle of a gigantic trilogy of books called The Three Body Problem. It's a Chinese science fiction series about aliens. It's not horror, it's thoughtful science fiction. It's called The Three Body Problem. They also made the first of the 3 books into a TV series, but there's 3 very big books, and I'm about halfway through book 2 right now.
So you like a fiction or non-fiction, detective, horror, comedy? I mean, what kind of book you like?
I read both, actually. I don't read medical, but I read sort of science. There's some excellent books like Missing Microbes, or some excellent thoughtful books on the biome and the world around us that I like. So I read nonfiction about the natural world, but I mostly like to read fiction when I escape science. When I'm not doing science, I like to escape to Mars.
So quickly tell me, how did you develop interest in FMT?
In gastroenterology?
FMT.
Yeah.
How did you develop that interest?
Mostly it was what I would say is role modeling. I was imprinting, I think a lot of us do that, but I knew some people who I thought had a really interesting mix of being thoughtful, cognitive. They weren't just doers. They weren't orthopedic surgeons with hammers, right? The GIs that I knew were thoughtful human beings, but they also were practical human beings. We do things, right? And for me, these were some role models that were, I thought, a nice blend. Okay. I didn't want to be just a hammer and saw person, and I didn't want to be...
You want to take a little different path, and you started thinking like, Ramesh, Rupraj, what is the last non-medical book you read?
It is a how to make habits.
How to make?
Can you hear me? Yes. It is about how to make habit. That means since childhood, how to inculcate in your practice of life as to how to have good habits or bad habits, whatsoever is. So try to inculcate in your children also the habits from the day one, as you have just rightly mentioned, a non-fiction book or a fiction book or anything, they should develop the habit of reading. Another thing is washing the hands. Like that, many of these things have been told in that book. So it's a very interesting.
Okay, very good, very good. So something really public health point of view. Matthew, what is the non-medical book?
Generally, I'm not a voracious reader other than the medical books, but the last book I read, not completed, still reading, is The Covenant of Water. Is actually written by Abraham Varghese from USA.
Oh, that's very interesting. Okay, so you get time occasionally to read some non-medical book too.
This book I carry in the flight to read, and after some day I sleep off.
Okay, Mohan, what is the book you read? So you may not get time at all now. 12 o'clock coming home, how can you read, no?
Yeah, I think.
Okay. Oh, you are already holding that.
Drive, fantastic.
Oh, right.
That is the energy of his.
No, the question got leaked, I think. You are already ready with the book, I think. Huh?
See,
Okay.
only
Unmute yourself. Unmute.
only myself and Mohan are in the hospital.
No,
I don't know anybody else.
Yeah, unmute yourself, and all of you can unmute yourself. Quickly, one more question. Ajay, then what is the book you read? Ajay, if not ready, then Ramesh, what is the book you read? And Rajesh, no, this is just to know that our readers, our viewers, or the delegates will be more to know about you. Okay, what is the famous quotation? You really love it and like it and really get inspired by this. Briefly answer all of you. Dr. Neil Stolman, what is a quotation or quote really inspires you in everyday life, or really what is that?
I'm sorry, I didn't hear it well, Dr. T.S. What is the what that inspires me?
What is the quotation or the quote or saying which you really love, which really inspires you? So brief to the answer. Amen.
I try to remember every day something that Dr. Christina Surowitz taught me, who's a C. diff matron, that while every day for me is the same, every patient, what they're doing with us is the most important part of their month, if not, longer, right? It's just another patient for me.
The saying should be very brief and to the point that really inspires you. So what is that?
I don't have a good one. I'll pass to the next person.
Okay, right. Now we'll move on. We'll come back to you. We'll not leave you. Rama, what is the quotation you really love, or you kept it in your consultation room or at home or anything like that? Really?
Okay, yes. I don't keep it in my consultation room, but since I was a child, ever since I was a child, Rudyard Kipling's "If" has been an inspiration. And let me just say the last two lines of that. If you can fill the unforgiving minute with 60 seconds worth of distance run, yours is the earth and all that's in it. And what's more, you'll be a man, my son.
Oh, very good. Matthew, what is the quotation you like to be? Really, you have been inspired. Okay, my God.
Now thy neighbor as thyself, which I practice in my life also.
Oh, that is said by great, no, Jesus Christ. Okay, you are truly following that. And Ramesh, what is the quotation? You love it, or you have
if
to
you
be
love,
quick to
if you love someone, show it.
Very good. How do you show it?
By doing what really your love is.
Okay, right. Mohan, what is the quotation? You like it?
I like Abdul Kalam's quotation that it is a crime to dream small, because if you cannot do big, but at least dream big and try to pursue that, pushing the boundaries, aiming high, thinking big. At least that should be done, and try to achieve that. And if you dream small, that's a crime.
Okay. TSC, time to leave.
Yeah, hi, sir. Good evening to all of you. Shubhendu here. Yeah.
Did we lose Dr. T.S.?
Yeah. We are just winding up in 2 to 4 minutes. We want to know about what is who is your favorite actor, Neil Stolman?
Oh, who is my favorite actor? Oh, that's a good one. I hadn't prepared these ahead of time. I love George Clooney. I just trust him. Not for no good reason, but he could tell me to jump off a cliff, I would jump.
Oh, very good. Rama, what is the favorite? Who is the favorite actor?
Okay. If I choose a favorite actor in the Hollywood movies, then probably it would be Harrison Ford.
Oh, very, very classical movie. Okay. And what about Matthew?
I like Malayalam movies. I like
Mohanlal.
Mohanlal.
Mohanlal. I endorse it. Mohan, who is your favorite? Apart
Amitabh
from Prabhas,
Bachchan.
another Amitabh Bachchan.
Yes.
Ramesh,
Mahesh Babu.
Mahesh Babu, Jayaraj sir.
So Tom Hanks in Hollywood,
Ah,
Amir Khan in Bollywood, and of course Rajinikanth in Tamil.
so you classify like that, huh?
Yeah.
Hollywood, Bollywood, Collywood, Tollywood. And the last question is, what is the message you would love to spread to the humanity? We'll start from Dr. Stolman. Very brief, that is the last, and after that, I will just thank you, everybody. While you are thinking that, I would like to thank you, our speakers, Dr. Neil Stolman and Dr. B.S. Ramakrishna, our moderators, Matthew Philippe and Ramesh Roy, and our panelists, Dr. Rajesh and Dr. Ajay, Dr. Mohan Ramchandani, and Dr. Ramesh, everyone, for this wonderful session. It's a unique topic, and you really carried the message so much. We have several hundred delegates from all over the world, and they're all been benefited, and we enjoyed it. I will come back to that. What is the message you want to spread to the humanity? Very briefly, Dr. Neil Stolman. Yes.
One word, love. Love.
Love. What about relove, huh? Ramakrishna?
Yes, so
What is that?
I'm from 1969. The make love, not war.
Make love. Now the third person should say anything apart from love. Okay, now we'll start with the Ramesh Rupdarji. What is the message? Unmute yourself, all of you. Just last message to the humanity. Matthew, what is your message?
I think life is a journey, and in that road, you will never get a chance to come back. So do whatever best while you travel or travel forward.
I'm glad that you did your best in this webinar. Okay, Mohan, what is the
I
message
think we
to
are.
the man?
Yeah, I think we are moving from intelligence to artificial intelligence, and then what changes us, keep us human, is empathy, and we, as a doctor, especially, must keep empathy to our patients, and keep
So
considerate for
love to empathy, empathy to artificial intelligence, everything. Okay, Ramesh, what is your message to the humanity?
There should be sincerity, hard work, and focus to develop India, one of the best in the world.
Okay, you are a very patriotic person, I agree. Ramesh, Roop
Yes.
Raji, what is your message?
Live in today, forget the past, and never bother about the future. What are you today? Remember it. And
Oh,
do the best.
very good, very good. Anybody else want to say anything? Raju, you are there on the screen. Okay, with these few words, ladies and gentlemen, and it is a great, yes, and we enjoyed interacting with you. We listened to the talk, wonderful, top class, and the beneficiaries are our patients through our doctors who have attended this. Thank you very much for this.
Thank you very much.
Thank you for having me.
Thank you.
Thank you so
Thank you
much.
very much.
Thank you.